Thank you for joining us for the first lunchtime webinar of 2012. My name is Karin Shaw, and I'm a member of the Alumni Affairs Office in the School of Public Health. We started these webinars about a year and a half ago in the hopes of giving alumni and friends ongoing access to some of the research and thinking going on here at the school. We would also like to hear from those of you participating about your public health experience, so we will allow time for questions and comments after the lecture. If you have a question, simply type it in the field at the bottom of the chat window in the bottom left-hand corner of your screen. Also, please feel free to give us feedback using the emoticons, a little box with a smiley face in the participants window. Today's lecture is held by Dr. Stephen Wallace. He is professor and chair of the Department of Community Health Sciences at the UCLA School of Public Health and associate director at the UCLA Center for Health Policy Research. Dr. Wallace is a leading scholar nationally in the area of aging in communities of color. Today's topic is economic and health security in old age. Do we know it when we see it? Dr. Wallace.
Thank you, and thanks everybody who's on the webinar today. I thought this was an appropriate topic because we talk a lot these days about social determinants of health, and economics is one of those key underlying social determinants of health. In addition, there's been a lot of discussion about the Affordable Care Act and how in moving to universal coverage with health insurance we'll have achieved a level of health security. And so together with the economic security, I wanted to tie that into health security a bit. So if you don't understand something as I'm talking about it, feel free to enter that into the chat screen. Otherwise, we will have 15 or 20 minutes at the end for a general discussion. Okay, so I want to start with how we define poverty today, how we know it when we see it. And I'm going to ask you in the chat box to answer who said this. I see 1/3 of a nation ill-housed, ill-clad, and ill-nourished. So in the lower left-hand corner you have a chat box. If you know the answer, type the name of the person who said that, the last name. I'm not seeing any names. I know at least one person on the webinar knows the answer. So it was Franklin Roosevelt, President Roosevelt, in the 1930s in his second inaugural, in reflecting on the depth of poverty during the Depression, said, I see 1/3 of a nation ill-housed, ill-clad, and ill-nourished. That was the technology that we had during the 1930s. Information on people who were struggling economically was impressionistic. They saw lots of people out of work. They knew that local governments were overwhelmed with people who needed financial assistance. But there really was no specific way to determine how many people in the country were not economically secure. Move forward to the 1960s, and we have President Johnson pictured here, who declared a war on poverty. Well, by that point, declaring a war on poverty required some sort of standard metric to determine whether or not we were making progress on that war. And there were a lot of different proposals for how we actually measured poverty. The political part of that measure was that the number had to be high enough so that a war on poverty could make measurable progress. But during the 1960s, we were also in a Cold War with the Soviet Union and China, and so there was also a consideration that the number not look so high that the country looked bad. So you needed enough people who were shown to be poor, who we could move out of poverty, but not so many that it would look bad internationally. So there are a number of different proposals for ways of developing a line for measuring poverty. The one that got adopted is the Official Federal Poverty Guideline, which we often abbreviate as FPL, was based on the most recent information available in the early 1960s. It may seem sort of strange now, but in the 1960s we still didn't have a whole lot of data on the status of people in the United States. So the most recent information that they had was based on the 1950s, mid-1950s survey of consumption in the United States. So I'm sorry, I just realized that we may not have been showing people the slides. Oh, we have been? Okay. So in the 1950s, the survey of consumption showed that about 1/3 of the average family budget went for food. So that was in 1955. And that was pretty much the information that they had in terms of consumption. And then they had data on how much it costs to buy food. So in a methodology that doesn't seem very sophisticated today, but used the best information available at the time, they took the cost for a minimal food plan, which was developed by the Department of Agriculture, and their minimum food plan, which was called the Economy Food Plan then, was the absolute minimum that you could spend on food and have a minimally nutritious diet for a short period of time. They multiplied that by 3, and that became the poverty level. And the car that I show here, for those of you who know classic cars, is an Edsel, which was considered the sort of one of the greatest flops in automotive history. And I use that picture advisedly because, well, it seemed like a good measure at the time. It has a number of problems. So the official poverty line, federal poverty line that we use today was developed in 1964 by Molly Orshansky. She was an economist at the Social Security Administration. She used that 3 times the minimum food requirement for the poverty line, and then varied that amount by family size. One of the key features of the poverty line was because the food costs were only calculated on a national level, and which is still true today. The amount was the same in every state. So whether you're in Los Angeles or San Francisco or New Hampshire or Iowa, the amount that the federal government says that you need to live on is identical. In 1969, they took that calculation and indexed it to the Consumer Price Index, which means that every year the amount goes up by the amount of inflation, but it only goes up by inflation. It doesn't reflect changes in the standard of living, in the changes in the composition of spending, and other things that change over time. So basically the poverty line, when you hear about the number of people in poverty in the United States, when you look at research about the association between poverty and health, we're talking about this index that was developed in 1964 and that was based on 1950s data. If you're interested, the citation at the very bottom provides a nice historical overview of how the federal poverty line was developed. So what does that mean today? In 2011, the official federal poverty line for an individual was $10,980. So that's less than $1,000 a month is what the federal government says you should be able to live on and have a minimum adequate standard of living. For 2 people, because of economies of scale, you can share an apartment. It costs less to cook for 2 than for 1. They calculated just under $15,000. So that's supposed to account for all of the spending that you need to make it through the day. So of course there's a couple flaws to that. For the elderly in particular, the federal poverty line does not take into account the cost of health care. Remember I said in 1955, 1/3 of family expenditures were for food. In 1955, the cost of health care and the way we paid for health care was very different. What this slide shows you is that in 2010, which is the most recent available data, older adults spend on average about 1/5 of their core expenditures for health care. So that's the little arrow, is that orange pie piece, compared to 7% of spending for adults under the age of 50, households under the age of 50. So there's a real significant difference, driven in large part by healthcare costs, in the spending patterns of older households and younger households. The other key piece here is that you can see that the component that goes for food is way less than the 1/3 that it was in the 1950s. In older households, 18% of core costs go for food, and in younger households it's even less, 12%. So the old standard that assumes that 1/3 of household expenditures go for food is no longer accurate. It hasn't been accurate for years. And the distribution of expenditures for older households requires that you take into consideration the out-of-pocket costs for healthcare as well. That's a major driver. So the inadequacy is not only that it doesn't reflect the distribution of costs, it is sort of prima facie inadequate. So you can see this is just housing costs based on the Department of Housing and Urban Development, which is the federal government. They come up with a series of housing costs for what they call fair market rents. This is the rent at which they're willing to subsidize houses for low-income individuals. Now, you may recall that I said in 2011, the poverty line was under $1,000 a month for an individual. So if you have a one-bedroom apartment in Los Angeles, the federal government says that a low-income person needs about $1,100 a month to rent almost $1,200 a month to rent a one-bedroom apartment. New York is even more. San Diego is not a whole lot less. And so what the federal government says you can survive on at a monthly level won't even buy you housing in major cities, Los Angeles, San Diego, New York. In Humboldt County, up in the far north, 100 miles from the Oregon border, the fair market value for a one-bedroom apartment is $700. And in a low-cost area, such as Fargo, North Dakota, it's under $500. So what this really gives you a really clear sense of is that the underlying costs, which is housing in this case, which varies the most, which is a major piece of the expenditures of individuals. So you can see here, shelter and utilities was 40 to 50% of the core costs. And those costs differ dramatically depending on where you are in the country, anywhere from $500 to $1,200 per month. So the fact that the federal poverty line doesn't vary at all by geography is a major problem. In response to that, we've been working with a number of partners in developing and refining the Elder Economic Security Standard Index, which we affectionately just short-term the Elder Index. The Elder Index is based on the standard of living of current older adults. It's based on how much they need to spend for basic goods and services. We build it on reliable, credible, publicly available data, so anybody can go and look and make sure that what's calculated is accurate. Most importantly, perhaps, it is specific to older adults at the county level, so those differences between San Diego, San Francisco, Los Angeles versus Fargo, North Dakota are incorporated in it. And it's relevant. It provides a measure of income adequacy, which we define as the amount needed to cover basic needs at a decent minimum level. The Elder Index was originally developed by the University of Massachusetts, Boston, collaboration with Wider Opportunities for Women. And we've been working here in California for the last 3 or 4 years with the Insight Center for Community Economic Development in Oakland, has been the partner in applying this to California and continuing to refine it. And let me show you a little bit about what an adequate measure of income security means. It means that you explicitly include the cost of housing. As I showed you earlier, that's the largest component of the costs that most people have in their daily lives. For the elderly, it's important to include the cost of medical care. Food at home continues to be a major cost, even though it's not the same extent that it was in the 1950s. And transportation is an important one. In the Elder Index, we also then include a category that covers other expenses such as telephone, clothing, home repair, and so forth. And details on the Elder Index, and this will be on the last slide also, you can go to our website at www.healthpolicy.ucla.edu/elder index, and all of the information on the elder index is available there, along with links to our state and national partners. So, as they say on public radio, let's do the numbers. So, what is the elder index come to in California? Well, as what you can see, 2009 is the most recent data that we've calculated the elder index for. We are currently updating it to 2010, and by the end of this year we'll have the 2011 numbers. But in 2009, the federal poverty guideline was 10,830. The elder index on average for California for a single person, for a single older adult, was 23,101. So what that does is that takes each of those components that I showed you earlier and adds them up and says what would an older adult need to actually meet basic expenses on average in California's counties. And I'll show you some county-specific examples in a minute. And it comes to over twice what the federal poverty guideline provides. Next to the statewide average, I give you a specific example, which is the city of LA, which is a little bit more expensive than the statewide average at $23,434. And in comparison, if you look at what the state provides as welfare for the aged, blind, and disabled, supplemental security income, or SSI, it's the kind of pink bar there, you can see that it's below the federal poverty guideline. So not only does state support for older adults not achieve the level that the federal government says, but it is way less than half of what the actual cost of living are in California. The set of bars to the right-hand side provide the same data on couples, and once again you can see that the federal poverty guideline at $14,500 is about half the actual cost of living. The state supplemental security income is actually above the federal guideline, which legislators often talk about as an area they could cut because it's overly generous in comparison to the federal poverty guideline, but it's still substantially below the actual cost of living for older couples in California. We've published information on this at the center. The most recent one was in September 2010, and this provides data that's some of the data that I'm showing you today, and this is available on our website. So the details of this, when you break it down and looking at the component costs, so I mentioned the city of Los Angeles and then Humboldt County. So when we were first calculating these, we thought, well, this might create some conflict because you'll have large cities, we all know, have very high housing costs, and as I showed you before, more rural areas like Humboldt County have much lower housing costs. So is this going to be a setting, an index where it creates conflict between urban and rural areas? You know, what this actually shows is it creates a lot less conflict than we anticipated, and here's why. If you look at the costs of housing, it is indeed for the city of LA, for a renter for one bedroom, it's over $1,000, and for a renter one bedroom in Humboldt, it's $600. So there is a very large advantage to living in Humboldt County in being able to find affordable rents. The costs of food are slightly higher in the city of Los Angeles, but not dramatically higher. Transportation, these are all the components that go into making the elder index. We actually show as equal. There is not good data that breaks it out at the county level. But then you get down to the cost of health care. And the cost of health care includes the cost of out-of-pocket medical expenses, but then also includes the cost of supplementing Medicare. So what most people who are under 65 don't realize is that Medicare has lots of areas that it doesn't pay for, including there's co-payments, there's deductibles, there are some uncovered services. So what most older adults do is they purchase out of pocket some type of supplement to cover the gaps in Medicare. There's two ways you can do that. In Humboldt County, we calculate that they go out and they buy an AARP Medicare supplement to cover the uncovered costs of the copayments for doctors, the deductibles for hospitals, and that they buy an AARP drug policy as well. So the Medicare Part D also has payments involved. That combined with out-of-pocket costs brings you up to $382 per month simply for making sure that all of your medical care costs are covered. In large counties like Los Angeles, you can get a Medicare Advantage plan such as Medicare Kaiser or one of the other HMOs, which includes those copayments, the deductibles, brings them down to a very low level, and includes your prescription drugs, similar to the Medicare Part D. In Los Angeles County, that is available at no extra cost. So the $182 that you see listed for healthcare costs is actually just the out-of-pocket cost. There are no extra fees involved. So when you add that all up, Los Angeles may cost more for housing, but it actually ends up costing less for medical care. And so the total elder index for Los Angeles is higher at $23,000 than in Humboldt for $20,000, but nowhere near as much as if you had only adjusted for housing. So what this really indicates is that when you're looking at economic security for older adults, you have to include both health care as well as housing because they're both important contributors to the costs of living. This gives you the actual dollar amounts here. So what you can see is, for example, in San Diego, Medicare Advantage at Kaiser is no extra cost. With a Medicare Advantage plan, you don't need Medicare supplement, you don't need a Medicare drug plan, so all you're really paying for is out-of-pocket costs and the Medicare Part B premium, which automatically comes out of your check. And that really drives the healthcare differences in those two counties. So how many people are we talking about? Is this just an interesting issue that really doesn't have a lot of policy relevance? Well, in reality, it really does. So remember earlier I said that on average in California, the elder index is at least twice the federal poverty line. What this shows you is what proportion of older adults in California by race and ethnicity fall under the official poverty line, and then how many more fall under twice the official poverty line. So most of or all of the people under that 200% of the federal poverty line are not going to have enough resources to make ends meet because they fall under the California Elder Index. In California, 9.1% of non-Hispanic white older adults fall below the federal poverty line. That's often seen as a low number, which it is compared to many other indices. What you see, though, is that a lot of older adults who are non-Hispanic white, and this is true across all races and ethnicities, basically sit right above that federal poverty line. They're between 100 and 200% of the FPL. And actually, those rates are higher than those that fall below. So while 9.1% of non-Hispanic whites are poor, you end up with 26.6% are under 200% of poverty. And when you get to the Latino population, you get 45% of the Latino elderly population in California is below 200% of the federal poverty line, which is a pretty good indicator that they're below the elder index. So that's really the basic cost of living in California. What that does is that says that of the 4.3 million older adults in California, 1.3 million don't have enough resources to make ends meet. That's the 200% federal poverty line. So we've been working on this for the last several years. Our community partner at the Insight Center for Community Economic Development in Oakland has done a wonderful job in doing community organizing and doing outreach to policymakers, nonprofit organizations, working with the media. So we've been the research side, they've been the policy side, and together we've had a fair amount of success. Last year on the front page of the New York Times, Sunday Times, which has the largest circulation, they ran a whole feature story on redefining poverty that really focused on the elder index and It's a little blurry, but you can see on the second column it talks about a recent UCLA study. Really looked at what poverty and economic insecurity in the state means. More recently, this last week, you may have seen another profile about people, older adults, who are struggling without enough funds, and because of the way the poverty line is defined, are not adequately counted. Probably our biggest policy impact to date is Assembly Bill 138 that Assembly Member Bell introduced. Was passed this last year and was signed into law by the governor, and it requires the area agencies on aging in California, which are the service providers for social services that receive federal funding as well as local funding. They put together 4-year plans and annual plans, and they are now required to include the Elder Index as part of one of their planning tools, so that they have a better idea about who is not able to make ends meet in their state and the best ways of addressing that. This was a 3-year process to get this incorporated in the California planning process. The first time it was proposed, Assemblymember Bell proposed it in 2009. It did pass the legislature, but it was vetoed by the governor. 2010 didn't make it through both houses of the assembly, and last year it made it all the way through, and we're now working with the AAAs and implementing this. Briefly, the Elder Index has also been used in a number of counties. I think interestingly, it's been used both directly and indirectly. In San Francisco, the city and county was developing a new program for persons needing long-term care, and they were trying to figure out what eligibility level to set for their public service. And the planners said, well, we should set it at 300% of the federal poverty line. And they were getting some pushback from local legislators saying, well, that sounds like an awful lot. 3 times poverty, isn't that awfully high? And what they did is they went and they got the Elder Index for San Francisco and said, well, according to the Elder Index, a minimum standard of living in San Francisco is close to 3 times the poverty level. And so 300 actually is a very rational eligibility level. It's not a high eligibility level at all. And so they actually use the federal poverty line, but they justified that particular level by looking at the Elder Index. Marin has been using it to show that there's a demand for low-income senior housing, because if you use the federal poverty line, seniors in Marin don't need any more subsidized senior housing, but the costs in Marin are a lot higher than what the poverty line would show you, and so they've been using it for that. San Diego Health and Human Services include the Elder Index, as do some of the other AAAs, in their reports on seniors in their area. And this is occurring nationally. So the Wider Opportunities for Women in Washington, D.C. has been working with 17 states, including California, in developing an Elder Index for their state and then promoting its use within the state. And they have funding from the Atlantic Philanthropies to do the calculations nationally and to expand the network. So this is a grassroots effort. It's a national grassroots effort to try to identify what is economic security for older adults and to be evidence-based and be grounded in reality for what it means. So economic security is linked to health security. If you look currently at how much older adults spend out of pocket as a percentage of their income, what you see is from the most recent National Medical Expenditure Panel survey that, interestingly enough, out-of-pocket costs for older adults are relatively similar regardless of their family income. So among older adults in families under the federal poverty level, that's the poor, they don't spend dramatically less than those near poor or low income. Those groups are similar to middle and high income. So it sort of makes sense. If you're spending about the same and you're low income, it's a much higher proportion of your income than if you're wealthier. So on the line with the triangles shows that Low-income older adults spend about 16% of their income on out-of-pocket health care costs. The highest income group only spends about 2% of their income. So the less money you make, the more of it goes for healthcare spending, which further complicates the economic security and the health security in old age. One of the biggest costs that aren't covered by Medicare that generates a lot of out-of-pocket spending is long-term care. Long-term services and supports for older adults provides the help that they need to live independently. If it's in your home, it can be something like a homemaker service, Meals on Wheels, adult day health care. There's a set of home care that is essential for older adults to be able to maintain independent living. The costs that are calculated also include nursing home care for people who aren't able to maintain living at home with support. What's important is that most people don't realize that those services are not covered by Medicare. So the UCLA Center for Health Policy Research has been collaborating with the SCAN Foundation for the last 2 years in conducting a public opinion poll of California voters aged 40 and over. And one of the questions that we ask, and this is similar to data that you see nationally, is does Medicare cover long-term services for nursing home care, and does Medicare cover long-term care supportive services for home care? Only 30% of the respondents correctly said no, Medicare does not cover long-term nursing home care, and only 20% correctly said no, Medicare does not cover long-term in-home care. So there's a large proportion, the majority of the population, that isn't aware that should they become disabled and need assistance as they get older, that Medicare is not a resource for them. Combine that with the fact that most people really don't know the chances that they will need some sort of long-term services and supports in old age, creates an even larger problem. So research shows that about 70% of people who reach age 65 will need some sort of in-home help over the rest of their lives. And so we asked the question, what proportion of older adults do you think will need long-term help at some point with their daily activities? And only about 2 out of 5 respondents in this poll of people aged 40 and over correctly answered 70% or higher. So most people don't realize that long-term care needs are common among older adults, and most people don't know that Medicare does not pay for long-term care, which would be okay if they could afford it, but most people, when told what the cost of nursing home care are, cannot afford nursing home care. So we asked them, how many months would you be able to pay for nursing home costs, which currently run about $6,000 a month if you paid for it privately, if this was happening now? And 2 out of 5 couldn't afford 1 month. About 2/3 could not afford more than 3 months. Only 1/3 could afford more than 3 months. So the majority of people can't afford nursing home care, and the same is generally true with home care. So home care costs are less, on average about $1,700 a month, and over half could not afford more than 3 months of in-home care. So people don't know what their risks are, they don't know that Medicare doesn't pay for this help, and they can't afford it, which really creates a situation of insecurity in paying for health care in old age. This is being ratified. The insecurity is being made even more insecure because with current budget cuts at the state level for low-income individuals, we're weakening the safety net. The state of California has reduced cash assistance through SSI/SSP over the last 3 years. They're in the process of reducing adult day health care, which is an out-of-home service provided to people who remain in their home. They're reducing the hours available for in-home supportive services, which is that in-home and hands-on support available. They've cut a number of California Department of Aging programs that provide supportive services, and they're reducing the payment rates for other providers through Medicaid. So if you are low income, the services and supports are being reduced in California. And the Innovative Act, part of the Affordable Care Act, that would have provided help in the future for all individuals, poor and non-poor, has been shelved. There was a provision in the Affordable Care Act called CLASS, Community Living Assistance Services and Support, that would have provided cash benefits to all persons who were eligible for services who are eligible because they needed services due to disability. It was designed to be universal but voluntary, so if you paid into premiums, you would have the support available. In the SCAN Foundation UCLA poll, we found that only 5% of people had even heard of this provision of the Affordable Care Act. I like to say it was the best kept secret. Unfortunately, due to partisan politics, there were some provisions that needed to be tweaked to make it possible to implement, and with all those tweaks, it's not implementable, and the congressional deadlock over a whole series of issues has meant that it has been shelved because it cannot be implemented as it currently is passed under the ACA. So it doesn't mean that it won't happen in the future, but currently health security in terms of being able to afford long-term services and supports in old age is being undermined for low-income populations through state budget cuts. The potential for shoring it up for the middle class has been shelved because of Washington politics, and so unfortunately long-term care services remain the Achilles heel in health security in old age. So overall, I've showed you that the federal poverty line is outdated, inaccurate, and inadequate. It may have been fine in the last century, but in the 21st century, it's not. We at the Center for Health Policy Research at UCLA have been working on the Elder Index, which does provide an accurate gauge of income needed for economic security by seniors. The Elder Index is part of a national movement to provide a evidence-based and up-to-date measure of economic security. It is getting wide visibility in the state of California and is being incorporated now into state law as part of the planning process. So we hope to see the Elder Index continue to gain use and visibility in the coming years. Part of health security involves being able to afford long-term care services and support. They will be needed by most people after they reach age 65 at one point in their life, but they are rarely planned for. People are not aware of them. People don't understand the financing for them. And usually what happens is people don't think about the issue until a crisis occurs, at which point it's too late. And the part of the Affordable Care Act that would have helped increase economic and health security through the CLASS Act has been put on hold. Hopefully not forever, but that's an area that we still need to do work on. And then my last point is I've showed you a lot of data, but data is only a means, it's not an end. So knowing what older adults need for income security, knowing that we need to have people in old age have access to long-term care services and supports for health security is important, but that's not an end in itself. We actually need that to move policy, to move services, and to incorporate that into our daily practice. But as a researcher, I also want to point out that data is necessary even if it's not sufficient. Without accurate data, we're flying blind. And I think the whole issue around the federal poverty line really shows that, because as long as we were using inaccurate data, we really didn't have a good picture of who did and did not have economic security. Without knowing what people understand about long-term services and supports doesn't allow us to highlight the programs that we need to institute. So we need both the data and we need the action. So thank you very much, and we've got 15 minutes for questions. If people have questions about the Elder Index, about long-term services and supports, or any other topics around economic and health security in old age.
Thank you, Steve. This is the Q&A portion of our program. So simply type your question in the field at the bottom of the chat window, in the bottom left-hand corner of your screen. And I get us started with one question that seems obvious. If the federal poverty line is so out of date, why are we still using it?
So this is a question that I've asked myself many times. Whenever I talk about the Elder Index and the federal poverty line, whether it's in class, whether it's in a community meeting with organizations, people always have this, well, of course, it's how could we still be using that? It's so out of date, it's so inaccurate. What is it that keeps people using this? And we actually have a study that we did of people in the legislature, mostly legislative aides that help the legislators write their policy. So I won't scoop us. That will be coming out in the next month or so, so keep an eye on our website for that answer. But the bottom line is that the federal poverty line has been included in legislation for so many years that any discussion about using any other type of measure creates a concern among legislators that it's going to cost them a lot of money. In fact, the governor's veto in 2009 of the bill requiring the Department of Aging to use the Elder Index just as a planning tool. It wasn't going to cost the state anything. It wasn't going to increase the number of people eligible for any program. But the veto message said that requiring the Department of Aging to use the Elder Index would create what they called cost pressure. That was a new term that I learned then. Cost pressure didn't mean that it would actually cause any costs to occur, but if we showed that there were more older adults in California who did not have enough means to have a decent standard of living, that it then might create within the legislature a movement to improve the coverage or the eligibility for programs, and so that would create pressure on costs. So there's a concern there as well. So it's a combination of the embeddedness in policies combined with a concern over what this means for budgets and several other issues that you can read about in our next policy brief. Okay, thank you. Are there any other questions? I don't see any participants quite yet, so I'll ask another one. Does disability contribute to income insecurity? I'm sorry, say that again? Does disability contribute to income insecurity? Right, so there's an ongoing research program that tries to disentangle the effects of health and poverty. And the conclusion is that it works both directions. So as people become disabled, they're less able to work, they have higher costs in a lot of areas. So it actually, being disabled, increases the rate of economic insecurity. So the issues around being able to provide supportive services for people as they become elderly and disabled is important in their ability to be economically secure in old age. But the other way works around as well. So if we don't have income security, and that was what I talked about in my introduction, is the social determinants of health. Poverty, income security, in and of itself is a cause of poor health and disability. That means that if we can pay better attention to the numbers of persons who are economically insecure and can help raise the floor and have more people who are economically secure that in the long run we'll actually have people who are healthier and fewer people who are disabled and need some of those supportive services.
Thank you. And it looks like we still have about 10 minutes. Could you maybe elaborate a little bit on where the United States stand in comparison to other countries? And are there maybe any things we can look to as a solution to our challenges?
Sure. If people follow the New York Times, about a week ago there was a very interesting report that they cited and had some nice graphs on not just income insecurity, but actually income inequality and the mobility of people between higher and lower incomes. And what they showed was that of the, I forget the exact number, 12, 15, 18 developed countries that they looked at, the United States had the highest level of both income inequality, so the difference between people at the bottom 20% of the income distribution compared to those at the top 20%, and that the United States also had among the lowest income mobility. So most people who are born in poverty remain in low income, maybe not the very bottom, but in low income throughout their lives, and people who were born, so to speak, with a silver spoon are more likely to hold on to that than countries such as the Scandinavian countries where there's a lot of income mobility. There's also not as much difference between the top and the bottom, so there's a lot more movement. But even countries like England and Australia that look more like the United States and Canada have a lot more income mobility. So if we pay more attention to the groups that are struggling, which are those that fall below the elder index, similarly there's an index called the Family Index, which looks at working families. So if we really pay attention to what it really costs to live in the United States, and then adopt policies that help people move into an area of income security, and we're not talking about everybody driving a BMW, we're simply talking about being able to afford rent in a decent house, to be able to buy nutritious food, to be able to get enough transportation to get to a decent job. But that in and of itself will have benefits for health and will bring us more in line with the rest of the wealthy countries in the world.
Thank you. And one last question. Is there any chance the Class Act will be revised?
So it's interesting. The Class Act, when it was introduced, was a pet project of Senator Kennedy, who passed away just before it was finally passed and signed into law. So that was sort of a tragedy. It was a bill that he'd been working on for 10, 15 years. So it actually was adopted with very little controversy in both the House and the Senate. There were a lot of controversies around the Affordable Care Act. The Class Act was not one of them. After it was passed, it became a target of partisan politics among those who are trying to undermine the Affordable Care Act. And one of the provisions specifically said it has to be self-financed, that it cannot rely on any public money, and that the Department of Health and Human Services had to certify that as it was being implemented, it would be in balance for the next 75 years. So that specific language, and then there were specific terms around who was eligible and so on and so forth. The problem was in designing the legislation, they didn't give the Department of Health and Human Services enough flexibility to tweak it so that they could actually provide with confidence those 75-year imbalance projections. So if after the next election there's a different configuration in Congress, it's possible they could go back and say, we want authority to change how long you have to pay into it before you get finances back, or we want to change how many years you can receive it for, because right now once you start getting the support, you get it for the rest of your life. So there's a number of relatively minor changes that could be made to create that 75-year actuarial balance that they're prohibited from because of the way the law was written. So it would take legislation through Congress to make that possible. It's not out of the question that that would happen. It is out of the question that it would happen in the current Congress. The other possibility, which was raised at a state legislative hearing I was at a couple months ago, was that it's possible the state of California could create a similar program that would provide a similar type of benefit for persons in California. Sort of be like a class act in California. Although right now the term class act has developed a partisan tone to it, so it wouldn't be called the class act, but you could develop something particularly similar to that at a state level. The states are often seen as incubators of policy innovation, and so since this hasn't been done before at a state level, maybe California could move forward and institute something like this to show that it was feasible and that the financing does work. So if we can't get it at the federal level, maybe it can move forward at the state level.
Well, wonderful. Thank you so much for sharing from the wealth of your experience. And thank you to the participants for continuing the conversation with us today. The initial goal was to open up the classroom to our alumni, but please spread the word to your friends and colleagues. We welcome anybody as we open up our classroom to present some of the best faculty work we have going on right now. And on the screen you see details for our upcoming webinar. Please mark your calendars for February 15th as Paula Tevro will speak to us. We look forward to it. And lastly, if you have any comments, ideas for future topics, then please type them in the box below or send me an email at kshaw@support.ucla.edu. Thank you so much for joining us and have a great day.
Bye-bye.